If you take cardiology, can you guess highest number of questions in PGI came from where? They came from the topic of hypertension. So let's make the beginning. What are the drugs which are called the first line of drugs for the management of hypertension? Arpan, Jyoti, Rituraj, Sharda, Rashmi and many more students who are all online attending from home. Welcome to all of you for the new session. Some of you are still heaving on the bruises caused by the recent PG entrance exam where you felt, oh, I would have read little more better kind of a feeling. So forget about the last debacle. We are ready for the next World Cup. Okay. So what is the first line of drugs in hypertension? Basically, diuretics, ACE inhibitors, then receptor blockers like Losartan, hydrochlorothiazides, but not prazosin. Prazosin is what? Alpha agonist or antagonist? Huh? Prazosin. Prazosin is a centrally acting alpha 2 or 1. What will be there? Postsynaptic or presynaptic? Alpha 1 is postsynaptic, alpha 2 is presynaptic. So clonidine like drugs basically are all centrally acting sympatholytic drugs. Okay, so prazosin is not included in the as a first line drug in the management of hypertension was the question of the PGI. There is a joint national committee. Every periodically it will keep giving recommendations how to treat. The most recent joint national committee JNC is JNC 8. So what are the recommendations of JNC 8? It said the target systolic BP, if the age of the patient is more than 60 years, target systolic BP should be less than 150 and diastolic should be less than 90. If it is less than 60, then target systolic BP is less than 140. More than 18 years age, and if the patient is having chronic kidney disease, then the target systolic BP should be kept less than 140. And more than 18 with diabetes, it should be less than 140. So this is the typical JNC 8 recommendations, which is a favorite question of the examiner. Then there are totally 7 recommendations given by the JNC. Don't worry, I give all that literature for you. So when to add a antihypertensive? What is the first antihypertensive that is better to be added? Whether to add 2 drugs or 3 drugs, and how to step up the antihypertensive therapy. All these concepts have been recommended very clearly by the Joint National Committee. We will give the notes of this. Don't take it tension kuch bhi nahi hai. So you can review that. So whenever the age is more than 60, the blood pressure target is systolic BP less than 150 and diastolic BP less than 90. Then once more, whether they are a non-black or a black race. Typically Indians have similar kind of epidemiological parameters like blacks. So initiate a thiazide type diuretic or a calcium channel blocker alone, or you can use the combination of these two. Earlier days, whenever any elderly person has an isolated systolic hypertension, what is the meaning of isolated systolic hypertension? That means diastolic BP is normal, but systolic BP is 170, 180. I say genome, like the population like that with isolated hypertension, elderly people, earlier recommendation is only start thiazide. But the current recommendation is you can start thiazide or calcium channel blocker or a combination of the two is the one which is basically recommended. So this is one of the favorite question. What is the first drug you want to start whenever there is a elderly person above 65, above 60, who has got a systolic hypertension above 120 50. What do you want to start? So what is your answer? You can choose either thiazide or you can choose calcium channel blocker, not beta blocker, not the alpha blocker, is what you have to basically remember. Now, what is the most specific test for the renovascular hypertension is one of the favorite questions of the examiner. So fundamentally, renal artery stenosis is one of the very challenging underlying causes for the systolic hypertension. They use magnetic resonance angiography. If you use MRI, pass a gadolinium contrast, take an image, that become MRI angiography, right? So that can be able to identify very, very sensitively and specifically the presence and the degree of severity of the renal artery stenosis. So that is the reason in the present scenario, the most sensitive, the most specific investigation for the renovascular hypertension would be MR angiography is what you have to emphatically answer. A person has got headache, profuse sweating, and on examination his BP is 200 by 120. Which drug you don't want to use is the question of the examiner. There are two kinds of hypertensive crisis: hypertensive urgencies, hypertensive emergencies. What is the main difference between these two? Urgency versus emergency. In both of them, systolic BP more than 180, diastolic BP more than 120 is called a emergency. But along with that, if there is signs of end organ damage, patient's urea creatinine elevated, patient has got severe headache, patient has got a focal neurological deficit like a stroke, patient has got MI, any of this end organ damage, if it is there along with this kind of a hypertension, systolic BP more than 180, diastolic BP more than 120, you call it as emergency. Whereas if the end organ damage is not there, but only systolic BP is more than 180 and BP, diastolic BP more than 120, you call it as hypertensive urgency, is what you have to basically remember. So whenever you have a hypertensive urgency or emergency, you can use sodium nitroprusside is the one which is the most preferred drug. Labetalol, what is the specialty of labetalol? It is both the alpha blocker and also a beta blocker. I think you all have got the funda about alpha and beta receptors. You have the heart where you have beta 1, you have the smooth muscle endothelium where you have beta 2, then you have alpha 1 which is there on the vascular endothelium, and then in the brain you have got the hypothalamus from where the sympathetic outcome comes out. Sympathetic outcome, yeah, now it's fine, okay. Is the voice volume is okay? Yeah. So here you are having alpha 2 receptors. Now what is the specialty of this alpha 2 receptor? If you stimulate it, then the sympathetic outflow become inhibited. If you stimulate alpha 2. So alpha 2 stimulation will lead to inhibition of the sympathetic outflow and it will act like a sympatholytic and it acts like an anti-hypertensive. That's the reason clonidine like drugs all act at the level of the alpha 2 by stimulating the alpha 2 and acting like a sympatholytic is what you have to basically remember. What happened? Is the voice fine? Okay. Please check whether the voice is clear. So, if you take the drugs like prazosin, how do they act? They basically block the alpha 1. Alpha 1 stimulation lead to vasoconstriction, and that is the reason it will rise the BP. So any blockade of this by using the prazosin basically will lead to antihypertensive effect. Then you are having the beta 1 receptors which are there on the heart. So your labetalol is fundamentally a combination of the two is what you have to fundamentally appreciate. So whenever you have hypertensive encephalopathy, what do you use? We use nitroprusside, calcium channel blocker like nicardipine and labetalol. If you have malignant hypertension, then labetalol, nicardipine and nitroprusside are the better choices. If there is a stroke, there also labetalol, nitroprusside and nicardipine. And acute left ventricular failure if it is there you can use nitroglycerine along with enalapril and loop diuretics is the combination which you will use if there is a congestive heart failure. If the patient has got an acute aortic dissection and you have to emergently control the blood pressure, then what is the better drug that you want to fundamentally use? In aortic dissection we use nitroprusside or a short acting antihypertensive like esmolol, and similarly labetalol are the ones which are the choice. You have a pheochromocytoma patient with a hypertensive emergency, then the choice will be phentolamine and nitroprusside. Then if you have a preeclampsia, we use Pritchard regime. Max sulfate we use, along with that we use hydralazine, labetalol or the nicardipine is the choice. So in which hypertensive emergency scenarios, what are the specific drugs that are the ones which are considered to be the drugs of choice? You need to have a clear-cut clarity. Now doctor, a 20-year-old has got a bilateral bruit in the flanks. His BP is 160 by 110, PGI June 2009 question. Then what is the true statement about this individual? So except C, everything is true. Enalapril will deteriorate his renal function. What is the enalapril fundamentally? ACE inhibitor. For a unilateral renal artery stenosis, ACE inhibitor is a drug of choice, but bilateral renal artery stenosis is contraindicated. The definite way that you can identify is MR angiography, contrast enhanced MR angiography. The condition is not always bilateral. Most often it is unilateral. Renal artery stenosis is what you need to remember. And suppose with the medical therapy, if the hypertension is not controlled in renal artery hypertension, what is the choice which is available for you? You can do a surgical intervention of correcting that stenotic renal artery by placing a stent inside it. So there is a reason surgical intervention can be used. And what is a very common cause of the renal artery stenosis, especially in a young female presenting with hypertension in Asia? Fibromuscular dysplasia is considered to be the underlying cause, is what you need to appreciate. Monogenic and autosomal dominant cause of hypertension is which one? Fundamentally, if you look at the genetics of hypertension, it can be multifactorial, polygenic, or it can be monogenic in nature. So out of all this, the pregnancy induced hypertension and glucocorticoid remediable hyperaldosteronism is an entity. In these two scenarios, fundamentally it is a monogenic kind of an inheritance. If you take the essential hypertension, which is a very common hypertension, when do you suspect essential hypertension as a cause of hypertension? Any hypertension in what age groups? Above 35, below 60 is considered to be essential. Any first time onset hypertension above 60 or below 30 is treated to be most likely to be secondary hypertension. Below 30, what are the causes of hypertension below 30? Renal artery stenosis, fibromuscular dysplasia, endocrine causes like Cushing's, Conn syndrome, they are all very common. Adrenal hyperadrenal adenoma, they are all very common below 30. Above 60, why? Secondary hypertension is very common. First time above 60 hypertension started. Above 60 people have atherosclerosis. Because of that the renal artery can undergo stenosis. And that can lead to secondary hypertension. Always secondary hypertension should be suspected when the first time onset of the hypertension is above 60 or below 30. And between the two, it is generally considered to be essential hypertension is what you have to basically appreciate. Now what are the various causes of secondary hypertension? Can the online students can punch? Gauri, Josna, Arpan, is the voice loud and clear for all of you? So the cause of secondary hypertension can be any of them. Old age, hypothyroidism. What is the fix in this question? Because hyperthyroidism lead to hypertension, we think hypothyroidism should lead to hypotension. No, doctor. So, you are a brilliant guy and did not read but got the seat. Can be equal to some of your classmates who are not that brilliant but they worked hard, then they will also get seated. So that applies in other scenarios, not here. Hyperthyroidism and also hypothyroidism, both of them lead to development of hypertension is what you have to basically appreciate. Very good. Thank you, Gauri. Loud and clear. So every year after the state MD entrance, All India PG is over, students, those who got seat will fill our mouth with a laddu. But those who didn't get the seat, there is nothing to dishearten. That means you tell 100 things, doctor. मैंने बहुत अच्छा पढ़ा, मैंने रोज मेहनत करके पढ़ा, मैंने पसीना पसीना निकाल के पढ़ा, but still मुझे सीट नहीं मिला. बोले तो जो जीता वही सिकंदर. So I tell my students that if you finished 600 topics from 19 subjects, those who didn't have the list of the topics, please take from our office. Once you revise them honestly, the missing theory part in the book whenever you wanted to review theory, and finished these 4 question banks last 15 years, PGI, AIIMS, DNB, JIPMA, if energy hai to All India. Lot of things are common only. Once you finish 600 topics, all these MCQs are like skating. You can finish in no time. If you finish, no one stops you from getting seat, doctor. But if you have not done that homework, it will be like Indian cricket team. Up to semi-finals आएगा आप, quarter-finals. Semi-finals level में थोड़ा, you should not be shaky in the era of competition. You should make 4 sixers in queue like the West Indies team, right? So about renal artery stenosis, already DNB question bank is available in the online video library. Please review. Topic wise similar discussion is being done. 150 hours we finish each question bank. All last 15 years DNB question bank, topic wise classified, 6,000 questions revised and uploaded into the online video library at anatomytomedicine.com. Then we are every Sunday finishing AIIMS question bank, right? Topic wise, subject wise. There's a schedule for that, please pick it up. Morning 9 to 7 p.m. we have the session every Sunday. Some of the best teachers come and teach other than medicine. Medicine we don't let anybody to teach because we feel we are born for that and we can't do anything else much better than this, right? So medicine I will teach. Then PGI JIPMA question bank I will revise for you between Tuesday to Friday, right? And review this. There is a immense amount of theory available in the online video library. Any topic you feel little shaky, go, click, you have got the theory video available. Strengthen the theory where you are missing, solve the questions. Nobody will stop you. Okay, that's the deal. And general benchmark. If you didn't clear DNB, you are not getting seat in state MD or All India. I can write it and tell you. If you are still dreaming, not even clearing DNB, thinking that, oh, I am going to get first 100 ranks, though I didn't qualify, or got 10,000 rank in DNB, bole to, wo to jhuti khwab hai. Right? So you have to clear DNB. That's a sign of your what you call academic potence. वो clear करके आगे बढ़ना है. Right? That's the reason keep the June as a target to get into the top 1000 in the DNB. That is the goal. Okay? Now, renal artery stenosis. What is the true statement? Most common cause is atherosclerosis, especially when the age is more than 60. Fibromuscular dysplasia is very common in the young people, and the involved kidney will become contracted. So asymmetrical kidneys is the feature in case of renal artery stenosis, and typically they show an elevated plasma renin levels. Once the renal artery stenosis is there, why there is an elevated plasma renin? Can you give me the board? Board में गए तो problem आता? No. So here I want to quickly review you 2 to 3 important concepts. Kidney you have, renal artery you have. Once stenosis is there, what will happen? The blood flow to the kidney decreases. So in the glomerulus surrounding that you have the proximal tubule, and here you have juxtaglomerular cells which produce the renin. When will they produce renin? Whenever the GFR decreases, that is a stimulus to produce renin. So when renal artery stenosis is there, renal perfusion decreases, RBF, renal blood flow diminishes. That will diminish the GFR, and that typically lead to increased renin formation. Increased renin in turn will go and stimulate the angiotensin and aldosterone production to get increased. So that is the reason you have in renal artery stenosis what kind of renin? High renin, high angiotensin situation is what you have to basically remember. That's the reason what is the drug of choice for a unilateral renal artery stenosis? ACE inhibitor is the treatment of indicated in unilateral renal artery stenosis is what you have to basically remember. Right. So how do we get the notes today? Notes. PGI and Jipper, all these notes which you are giving to them, put as a blog on the newsformedico.com and also provide them in the downloadable PDF. Now, if you look at the arterioles of that kidney which is involved in the renal artery stenosis, will it show more atherosclerosis compared to that of the uninvolved kidney is a very important question. Generally, whenever a kidney is there, renal artery stenosis, whenever it is there, that kidney which is ischemic, the renal vessel supplying that ischemic kidney is protected from the effects of high pressure. That is the reason the arteriosclerosis that you see in the kidney, where renal artery stenosis is there, is lesser compared to the other kidney which has got a normal renal artery. The other kidney's renal artery is the one which shows higher amount of arteriosclerotic changes, and the particular stenosed renal artery is there, no, which is leading to ischemia of the kidney, that will show lesser amount of arteriosclerotic effects is what you have to remember. What is this called as? Goldblatt phenomena. It is called Goldblatt phenomena. That is, the contralateral kidney which is non-ischemic is the one whose renal artery will show higher amount of arteriosclerotic changes than that of the kidney which is suffering from the actual renal artery stenosis is what you have to basically remember. Now coming to the renal artery stenosis once more, in PGI, ACE inhibitors can be used. Can you use them? In bilateral renal artery stenosis you cannot. Then you don't do any excision and grafting as a treatment. You will put a stent as a treatment. You can use unilateral renal artery stenosis ACE inhibitors, and if you use ACE inhibitors, especially whenever hypertension along with diabetes is there, in such people ACE inhibitors are the first drug of choice because they will prevent the progression of the kidney deterioration in those who have diabetes. Diabetes means, what is the challenge in diabetes? Diabetic individuals are more prone for diabetic nephropathy. Diabetic individuals have got a poor lipid profile. That's the reason they are prone for atherosclerosis. Because of the atherosclerosis, they get hypertension. To treat hypertension, we use ACE inhibitors. The same ACE inhibitor will also help to prevent the progression of the diabetic nephropathy. That's the reason it is the best drug, is what you need to remember.